in people with chronic kidney disease. This webinar series is coordinated by the Aging Initiative, which is an NIA-funded initiative that bridges the expertise and leadership of two powerhouses for research on multiple chronic conditions. The two powerhouses are the Healthcare Systems Research Network and the Claude D. Older Americans Independent Centers, or PEPPER Centers. The Aging Initiative is led by Dr. Jerry Gurwitz at University of Massachusetts and Myers Primary Care Institute, along with co-PIs, Elise Adams and Jay Magaziner. My name is Heather Whitson. I'm an Associate Professor of Medicine and Ophthalmology and the Deputy Director of the Duke University Aging Center. And I'm part of the Aging Initiative Dissemination Workgroup, which is co-led by Dr. Leah Hanson at HealthPartners. Before we get started, I'm going to cover a few technical details. Due to the number of registrants for today's webinar, we have placed the phone lines on mute to reduce audio feedback. So unless you are logged in as a host or panelist, your line is muted. However, we do welcome and encourage audience participation using the Q&A and chat features of the webinar software. So if you're in your Cisco webinar portal and you look at the row of circles across the bottom center of your screen, you can click on the chat bubble icon until it is highlighted blue. And if you have questions for our speakers, please click on the Q&A tab on the right side of the screen, and you can type into the Q&A box. Leah and I will be keeping an eye out for those questions under the Q&A icon, and if time permits, we will read questions for our speakers after the presentations. If you have technical or logistical questions, we ask that you submit those using the chat box that is above the Q&A box. Please make sure that you are identified either by your name or your participant ID, so that our webinar hosts will be able to help troubleshoot any problem that you're having with audio or other issues. With the chat function, you can choose whether you would like your comment to be visible to all participants, or you can choose to send the question only to the hosts. And we want to extend a huge thanks to our hosts, Catherine Anzoni and Chris DeLude at the Myers Primary Care Institute, who do an amazing job behind the scenes to make these webinars possible. They'll be monitoring the chat functions today to help with the technical troubleshooting. And now I'd like to introduce today's speakers. We will have three speakers today. The first is Christy Reynolds. Dr. Reynolds is a chronic disease epidemiologist and director of the epidemiologic research for the Department of Research and Evaluation at Kaiser Permanente, Southern California. Dr. Reynolds has devoted her research to the prevention and treatment of chronic diseases and to the quality of care and outcomes for patients with chronic diseases. We'll also hear from Dr. Manjula Corella Tamora. Dr. Tamora is a geriatrician with research training in population health and chronic disease epidemiology. She's the Associate Director of Clinical Programs at the Durham VA Geriatric Research and Education Clinical Center and an Associate Professor of Medicine in the Division of Geriatrics, and research focuses on kidney disease and multimorbidity. She uses large clinical and administrative databases and is at, sorry, I was reading part of the next speakers, at Stanford University and director of the VA Palo Alto Geriatric Research and Education Clinical Center. Her research program is broadly interested in evaluating treatment practices and quality of care for older adults with chronic kidney disease. Finally, we will be hearing from Dr. Barrett Bowling, who is also a participant in the pilot work. He is at the Durham VA GREC and an Associate Professor of Medicine in the Division of Geriatrics at Duke and a Senior Fellow in the Duke Center for the Study of Aging and Human Development. His research focuses on kidney disease and multimorbidity using large clinical and administrative databases, and also partners with nephrologists to develop clinical programs in the VA designed to provide patient-centered geriatric care for older adults with kidney disease. So without further ado, I would like to go ahead and turn it over to our first speaker. Manju, it looks like it's you, and let us know if your audio is on.
My audio is on, but I don't think I'm the first speaker.
Yeah,
I think it's Barrett.
This is Barrett. Yep, I think I'm first.
Barrett's our first speaker. Okay.
Are my slides showing up?
Yes, we see your slides.
Okay. Okay, great. Well, thank you so much for the opportunity to talk about our work in the development of a chronic kidney disease discordance index. This was a collaboration between investigators at the Duke Pepper Center and Kaiser Permanente, Southern California. And this project has been a lot of fun to work on. I'm going to start off and talk about the background and some of justification for why we did this study, and then talk about our study design. And then I'm going to hand things over to Dr. Christy Reynolds, and she'll describe our results and conclusions. I'm starting with a quote from a patient who has moderate to severe chronic kidney disease who was a participant in one of our prior studies. This is somebody who wasn't familiar with the multimorbidity research or the multiple chronic conditions terminology, but he knew very well that patients like himself have multi-problems. He went on to tell us that you go to the nephrology people, they don't talk anything about diabetes or about your heart or whatever the case may be. Seems like there should be some coordination amongst them. Now, wait a minute, this guy has a heart problem too. What are we going to do about this? Or now, since he has all three conditions, what kind of instructions are we going to give him? And I think this is describing the type of care that all of us would want. It's individualized. It's has recommendations that are based on all the conditions you have, not just thinking about one problem at a time. But to get to this level of care, clinicians need to be aware of all the other problems that patients have, and they have to have an understanding of how those other problems might impact the current condition that they're taking care of. And so our pilot was designed to answer the question, can we use data that's already available in the electronic medical record to identify co-occurring conditions that are important in chronic kidney disease? And then can we develop a way to summarize and present this to clinicians in a way that would be helpful? It's important to study kidney disease in older adults because the majority of people with CKD are older. The prevalence has been increasing over time, and this is compounded by the fact that the population is aging. And so you can see that in this figure here, where we're looking at the number of U.S. adults 80 and above who have reduced GFR. On the y-axis, we have the rate, or we actually have the number of people 80 and above in millions. And on the x-axis, we're looking at calendar periods starting from 1988 to 94 and then projected out through 2050. We're looking at two levels of kidney function, those with estimated GFRs less than 45 to 59 and less than 45. And so this is kind of one of the ways that we define chronic kidney disease, with less than 45 being a more severe or more persistent reduction in their kidney function. And what you can see is that over time, the prevalence has increased, the numbers in millions has increased, and this is going to more than double in the next 30 years. And there's importantly been a disproportionate increase among those with more severe reductions in kidney disease, defined as estimated GFR less than 45. So an important problem for the nephrologist, but I think also an important problem for all of us because these patients, like we heard on the previous slide, don't have just kidney disease. We've known for a long time that chronic kidney disease patients have lots of medical problems, that if you're a patient with CKD and you have more chronic conditions, that's bad. But what's new here is this idea is not just the number of conditions you have, but how those conditions interact and what are the patterns of that. And really, there have only been a few studies that have characterized patterns of multimorbidity in CKD. One of the frameworks that I like is one that considers conditions as being discordant versus discordant. And so concordant conditions are those that are part of the same pathophysiology, and oftentimes they're part of the same disease management plan. So an example, you can imagine patients with diabetes and hypertension, both of those, a treatment plan is to try to prevent cardiovascular events. In contrast, a discordant condition is a situation where those conditions aren't directly related, or there may even be an issue where one condition worsens the other. And so an example with diabetes might be COPD, where treatment with steroids for COPD can improve dyspnea and improve quality of life, but might worsen diabetes control. I think this concept is particularly relevant in kidney disease because these patients already have reductions in their kidney function. They're at risk for having drug-related kidney injury. There are already these restrictions in what medications we use, and so there are these limitations that are already on them. We've tested this hypothesis that having discordance in kidney disease patients is associated with bad outcomes in some previous studies. And one of those we actually tried to find, okay, well, what are a list of concordant versus discordant conditions? Because this is not something that was already available in the literature. We used a two-step process for this. First, we had nephrologists go through and categorize conditions as either being concordant, discordant, or unrelated. And then in situations where there weren't complete overlap or agreement between the nephrologist, which is often happens with nephrologists, we then went on to the CKD clinical practice guidelines and said, okay, can we use the guidelines to help inform what conditions might be categorized as concordant versus discordant? And this figure shows the final list shown here in alphabetical order. And for these purposes, we grouped those that were considered either discordant and unrelated, and I think that's similar to the literature. We then conducted a retrospective cohort study of more than 800,000 veterans with kidney disease and found that CKD discordance was associated with hospitalizations and ED visits. Looking at the panel of hospitalizations, here we're looking at the rate per 1,000 person years on the y-axis. On the x-axis, we're looking at the number of total chronic conditions that they have. In the solid bars are those with all concordant conditions, and the open bars are those that had one or more CKD discordant conditions. So at least one of those conditions from that right side of the panel in the prior slide. And what you can see is that at every level of chronic conditions, at every level of multimorbidity, having just one or more CKD discordant conditions is associated with higher rates of hospitalizations. It's even more true for ED visits, and we also found a similar pattern with mortality. And these associations were persistent even when we adjusted for other potential confounders. We also have some qualitative evidence that supports this idea that CKD discordance, from the patient's perspective, is a major barrier to CKD self-management. So to orient you to this table, in the first column, we're looking at the CKD treatment advice. In the second column, we're looking at the comorbidity that the patient has. The next column describes the treatment advice for that comorbidity, what self-management situation, as we've labeled it, and then the last column is looking at a quote or an example of that conflict. And so just following across that first row, a common treatment advice for CKD patients is avoid NSAIDs. Well, if you have arthritis or gout, taking NSAIDs may improve pain, it may improve quality of life, and so this is a situation of discordance. And one patient described this to us when he said, last week I had a tremendous gout attack, I was in excruciating pain, so I took some Aleve, which I'm not supposed to take, but it relieved the pain that I had, and it was the only thing I had that would relieve the pain. I think this is an example of where this patient was stuck between making these difficult decisions, and this was actually a distressful issue for him because he knew the challenges related to CKD and taking NSAIDs. Another issue where this came up, or situation where this came up, was in heart failure. One patient told us, one doctor says drink a lot of water, another doctor says you're drinking too much water, well, what is it? And so here is an example of a patient who's given conflicting advice, at least as he heard it, and was sent home really having to kind of reconcile these differences on his own. So it's with these past studies in mind that we developed this one-year pilot study to address multiple chronic conditions in older adults with chronic kidney disease. We used a prediction model approach, and we're going to describe that in the next couple of slides and in our results, to develop a CKD discordance index, really with our long-term goal of being able to use information from the electronic medical record, integrate this clinical data, and present it to clinicians in a way that could be easily summarized and have potential practical application. This was a retrospective cohort study. Included older adults with incident CKD defined as an estimated GFR less than 45. And we chose less than 45 because that tends to be where complications might start to arise, where patients may be more likely to have been diagnosed with having kidney disease, or more challenges related to discordance might begin to occur. Data were from Kaiser Permanente, Southern California, and we used a split sample approach. We had two steps in this. The first step was we developed a prediction model for the one-year risk of unplanned hospitalization. And we chose unplanned hospitalization as our primary outcome because oftentimes a hospitalization may signal that something's gone wrong with the chronic disease management plan. And so patients with chronic disease then have some acute event or something that can't be managed as an outpatient resulting in a hospitalization. we used the prediction model first to guide the inclusion of conditions in our discordance index. And then second, we also use this to help us decide, well, should we weight these, or because some conditions may be worse than others. In the second step, we calculated the CKD discordance index, and that ranges from 0 to 1, and we'll describe that later in the results. And then we tested the associations of this newly developed CKD discordance index with hospitalizations, ED visits, and all-cause mortality in that testing sample that we described. We started off with those discordant conditions that we described in a previous slide, but then we had the question, well, are there other markers or other evidence of discordance that we could get from the electronic medical record? And so this table shows some of the other things that we were interested in. We were interested in medications, and we looked at some that might be contraindicated in certain levels of kidney function or certain stages of kidney disease, or those that may require a dose reduction. We were also interested in this idea of care continuity. This is something that had come up in our prior focus groups, that oftentimes patients describe discordance because one doctor says do one thing and another doctor says something else. And so we chose to use the number of medication prescribers as a proxy for continuity of care. This has been shown to predict outcomes in chronic disease in prior studies, and it also has a real advantage of being a simple way to measure care continuity. And this figure just shows our overall study design. This was a retrospective cohort study. We had a one-year look-back window where we determined the discordant conditions and other measures of discordance. We had our incident date defined as an estimated GFR less than 45. And then our primary outcome was unplanned hospitalizations. Patients were followed up to a year and censored after the primary outcome, date of death, starting dialysis, or if they disenrolled from Kaiser. I'm going to turn things over to Christy at this point.
All right, just want to make sure everyone can see my screen.
Yep, it looks good.
Okay. So we had approximately 3 million Kaiser Permanente Southern California members who had a serum creatinine measure between January 1st, 2008 and 2014. There were about 53,000 or about 54,000 adult patients who had at least 2 consecutive eGFR measures less than 45, which were separated by 90 days. Those were our qualifying criteria to meet the definition of CKD. We also, because we wanted incident CKD, we excluded patients who did not have at least one eGFR greater than 60 prior to the first eligible eGFR. We also excluded patients, about 600 patients who had ESRD or end-stage renal disease prior to enrollment. Leaving us with about 41,239 patients with incident CKD. We also excluded patients who were missing BMI, systolic or diastolic blood pressure, and about 1,200 patients, not shown here, but that had who did not have 12 months of continuous membership or a pharmacy benefit, and about 8,400 patients who were less than 65 years of age, leaving us then with an analytic cohort of 30,932 patients with incident CKD 65 years and older. And this population was then randomly split into the 3 data sets, the development cohort, the validation cohort, and testing cohort, each about 10,000 patients. Okay. So in the overall cohort, the mean age was about 78, 55% were female. It was a very diverse population, approximately 59% white, 7% Asian, 12% Black, and 20% Hispanic. And of the 30,932 patients in the cohort, approximately 32% had an unplanned hospitalization within the 1 year following the index date, which was the date of the second eligible eGFR. in the overall cohort, stratified by those who had a hospitalization in that post 1 year versus those who did not have a hospitalization, we see that those who were hospitalized were, sorry, are you seeing that the presentation that, I see the presenters on the right. You're not seeing that on my screen, are you? It's not distracting? Okay, I'll keep going. Just want to make sure.
Sorry, I was unmuting. I don't think we're seeing what you're seeing. Okay, great. Okay.
So those who were hospitalized were slightly older, and they were more likely to be male and have advanced CKD with an eGFR less than 30. They're also more likely to have a hospitalization or an emergency department visit in the year before study entry. And they were more likely to have 4 or more unique medication prescribers, so 39% in those hospitalized versus 23% non-hospitalized. We used this as a measure of, or a proxy for continuity of care, as Barrett had mentioned. We also, so those who were hospitalized in the year after the index date were also more likely to have discordant conditions. So, for example, 22% in those hospitalized had heart failure versus 9% in those who did not experience a hospitalization. Those hospitalized had a mean of 1.3 discordant conditions versus 0.9 in those who were not hospitalized. We also found that use of 2 or more medications contraindicated in CKD, or medications that require a dose reduction in CKD, was slightly higher in those hospitalized versus not. We looked at baseline characteristics between the three cohorts, the validation, development, and test cohorts, and there were no significant differences among those cohorts. So in developing the prediction model, so our full model, which is shown on the left here, had 40 variables. So narrowed it down to get it on the screen here. So we're showing some of the selected concordant conditions and the discordant conditions, as well as the prescribers. So our indicators of discordance associated with statistically significant high risk of hospitalization included heart failure, GERD or peptic ulcer disease, COPD, and cancer, as well as the presence of 4 or more prescribers. Hazard ratio there showing of 1.2. Not shown here, so we did have some there was not statistically significant conditions of osteoarthritis, dementia, and depression. They had p-values between 0.5 and 0.05, and so they were retained in the simplified model. In our simplified model, which included 21 predictors, including 8 indicators of discordance listed there, these 21 predictors explain 98.1% of the variance accounted for in the full model. We're still seeing significant associations with heart failure, borderline osteoarthritis, GERD, depression, COPD, and cancer. And again, the more than 4 prescribers. At the bottom, we show the C statistics. So in the internal validation using the development cohort showed a C statistic for the full model of 0.7, ranging from 0.69 to 0.71, while the C statistics of the simplified model was 0.69, ranging from 0.68 to 0.70. The 2 models had identical C statistics in the validation cohort. So this figure illustrates that the predicted risk of hospitalization, which is shown in the lighter color bars, from the simplified model was close, so about within 5% to the observed risk shown in the darker bars for all deciles of predicted risk, except for those subjects with the the most hospitalizations, so at the tail end. We then, in developing the CK Discordance Index, as Barrett had mentioned, we used a point-based system. So the indicators of the discordance, we used the regression coefficients, which were translated then into risk scores, which larger hazard ratios were assigned more points. So, for example, we see their heart failure has points of 29 that corresponded to a hazard ratio of 1.37, versus depression, which has a lower score of 4, corresponded to a hazard ratio of 1.05. The maximum number of points that somebody could get, so somebody had all 8 indicators of discordance, would be 124. So in the example we have here, a patient with heart failure and depression would have a CKD discordance index of 0.27. So adding up the heart failure points of 29 and depression of 4 divided by 124 is, it gets to the 0.27. So then to test the associations between this CKD discordant index and the risk for our outcomes of interest, hospitalization, ED visits, and all-cause mortality, we used predefined cut points and categorized those cut points into, shown here, a 0, a CKD discordant index of 0 to 0.24, and then an index greater than or equal to 0.25. And in this slide, then, we're showing from the Cox proportional hazards models with a 0 discordant index as the reference group, compared to those with a CKD discordance index of 0. A multivariate hazard ratio for the hospitalization was 1.39, ranging from 1.27 to 1.51. And 1.81 for those with the highest CKD discordance index. We see for emergency department visits and mortality similar association, similar patterns. So in conclusion, or in summary, so we did, using this large cohort of adults with incident CKD, we were able to develop and validate a prediction model for hospitalizations that incorporated evidence of discordance from using the EHR data. We identified several variables, right? 8 factors that, including heart failure, GERD, osteoarthritis, dementia, depression, COPD, and cancer, as well as having 4 more prescribers in the year prior to the CKD discordant index, the CKD diagnosis that were relevant in our discordance index. So these, we think that these inclusion of looking at these conditions may be helpful then in predicting unplanned hospitalizations, recognizing that this prediction model might be used to guide selection of conditions. And that we found that higher discordance was associated with higher utilization and mortality. So, some of our additional steps, we recognized that this was in one healthcare system, so it does really needs to be validated in other CKD subpopulations or other systems. It's also possible that because we used EHR data alone, we're not able to model potential indicators of discordance that are not captured in EHR, so such as lifestyle recommendations or dietary supplements, geriatric syndromes. So further work is needed to not only validate but refine the discordance index. But with that said, we believe that this index shows promise as a prediction tool for risk stratification, potentially for pursuing interventional studies and targeting this high-risk population. So we wanted to thank the Duke Pepper Center and the KPSC team, including Dr. Rashida Hall, Dr. Hui Zhao, and Teresa Harrison, and also the Healthcare Systems Research Network, Older Americans Independent Centers for Aging Initiative for funding this pilot work. I think that's it, so we will.
All right. Thank you so much to both of our speakers for an excellent pilot project and interesting findings. I want to do two things. One is to remind all of our participants that if you have questions for any of our speakers today, please use your Q&A function, and Leah will be monitoring that, and then after the next presentation, we'll read some of those questions. So if you do have questions for one particular speaker, please let us know if it's directed to one person in particular. We can also take questions that are more general. I also just want to introduce Manju Tamora again, because some of you may have noticed even before I did that my scripts were reversed, and Manju is in fact not at Duke. She is a professor of medicine at Stanford University and the director. Were you quite surprised that you transferred? She is the director of the VA Palo Alto Geriatric Research and Education Clinical Center, and her research program is broadly interested in evaluating treatment practices and quality of care for older adults with chronic kidney disease. And one thing that we asked her to speak particularly about today is one of her interests, which is understanding mechanisms and outcomes related to cognitive impairment in chronic kidney disease. So, Manju, as much as I would love for you to come to Duke and the Durham VA, apologies for that earlier.
No problem. Thank you so much, Heather.
Sure.
This is one time of year in the middle of March Madness where I do actually really miss being back in Durham.
I know. It'd be a good time to be here.
Yeah. I just want to check and make sure my slides are displaying okay.
Yes, they sure are.
Okay. Okay, great. Mm-hmm. So thank you so much for inviting me to participate in this webinar. I really enjoyed Barrett and Christie's presentation, and I think I hope you'll see that it segues really well into some of the things that I have been working on and interested in, and so much so that I decided to borrow one of their slides to introduce my topic today. So as Barrett had mentioned, chronic kidney disease is exceedingly common in older adults, affecting nearly 5 million adults over the age of 80, and its prevalence appears to be increasing. CKD, as you've just heard, rarely occurs in isolation among older adults, and in fact, I might make the argument that CKD is one of the prototypical multimorbidity conditions. Among those conditions that frequently travel with CKD is cognitive impairment. And although its burden is generally underrecognized, its impact on the patient with CKD is probably substantial. Cognitive impairment probably plays a central role in how patients manage, or in many cases fail to manage, their CKD, from aspects ranging to medication adherence, to dialysis decisions and end-of-life planning, which is how I really got interested in this area. So what I want to explore in the next 20 minutes or so are the interrelationships between CKD and cognitive impairment and dementia. Chronic kidney disease and dementia both increase in prevalence with age, and the two conditions share several risk factors which suggest that they might have a common pathogenesis. And so a better understanding of the nature of this brain-kidney condition may shed light on ways to treat or prevent both conditions. Because of the similarities in the vascular supply of the kidney and the brain, a common vascular etiology has been suggested as a link. In fact, both the kidney and brain are low-resistance end organs exposed to a high volume of blood flow, makes them susceptible to vascular damage, and which is why their blood flow is tightly autoregulated in both organs. And so it may be that impairments from vascular damage in one organ, which are manifested by albuminuria or reduced GFR, is paralleled by impairments in the other end organ, which are manifested by cognitive impairment. So if that's true, then we can exploit these interrelationships to further our understanding of the pathogenesis of both conditions. So for example, while cognitive function is somewhat difficult to measure and the existing measurements are imprecise, kidney function is much easier to quantify precisely. Along the same lines, brain tissue for research is generally not accessible until autopsy, whereas kidney tissue is more readily accessible. And on the other hand, brain imaging techniques are much more advanced than available kidney imaging modalities. So these are some areas where we might exploit the interrelationships to further our understanding. So the working hypothesis that I'd like to put forth is that CKD is a useful model for understanding vascular contributions to dementia. And to support this hypothesis, I want to review the evidence linking CKD, vascular disease, and dementia. And then I want to review some of the studies evaluating the effect of blood pressure interventions on brain health in persons with CKD. So the first line of evidence linking CKD to cognitive impairment and dementia comes from observational studies. The severity of CKD is assessed by the level of kidney function, which we estimate by the GFR, or glomerular filtration rate. And as you've heard, levels of GFR below 60 are categorized as stage 3 CKD, while kidney failure is defined as a GFR below 15 or the need for dialysis or transplantation. The bottom panel is illustrating the prevalence of cognitive impairment in a large population cohort by level of GFR. And what we see is that as the severity of CKD increases, the prevalence of cognitive impairment also increases. Moreover, a parallel relationship is observed between the severity of kidney disease and prevalence of cerebrovascular disease, which is shown in the orange bars. Several prospective studies also indicate there is an independent association between markers of kidney disease and the risk for dementia. So for example, in the cardiovascular health study, which is shown in the left-hand panel, CKD was associated with a nearly 50% increase in the risk for dementia, even after accounting for other traditional dementia risk factors. Similarly, in the 3C study, albuminuria, defined here as greater than 30 milligrams of urine albumin per gram of creatinine, was also associated with an increased risk for dementia. And what you'll note is that in both studies, kidney disease was strongly associated with vascular dementia, whereas there was a weaker or non-significant association between kidney disease with Alzheimer's dementia. So the second line of evidence linking kidney disease and dementia through vascular mechanisms comes from neuroimaging studies. In multiple studies, CKD is associated with a higher prevalence of subclinical brain lesions, even after accounting for other vascular risk factors. So different studies have demonstrated associations between CKD and lacunar infarcts, shown in panel A, white matter lesions, shown in panel C, and more severely in panel D, and cerebral microbleeds, which are shown in panel B. And as this audience probably knows well, these lesions are strongly associated with dementia risk in the non-CKD population. Thirdly, vascular lesions associated with white matter hyperintensities in the brain. For example, in this slide we're showing on the right-hand side arteriolar intima media thickening and lipohyalinosis from a brain autopsy sample of a patient with white matter hyperintensities. These lesions are analogous to the vascular lesions that we see in patients who have non-diabetic chronic kidney disease. So I'm showing you a biopsy sample of a patient on the left-hand side of a patient with what we've typically ascribed to hypertensive chronic kidney disease, and you can see the arteriole with hyalinosis right there in the center. So this is a model of cognitive impairment proposed by Marshall and Lazar, in which vascular risk factors induce atherosclerosis, arterial stiffness and endothelial dysfunction, leading to vascular changes of microvascular disease, macrovascular or large vessel stenosis, and cardiac failure. And then these vascular changes lead to end organ effects manifested by cognitive impairment. And so a very similar model could be proposed for kidney function impairment, explaining why the two conditions frequently co-occur. And if this is accurate, then we might expect that treatment of vascular risk factors would have similar effects on both end organs. So I'm going to focus on blood pressure interventions since hypertension is one of the most prevalent vascular risk factors, and because there's so much controversy surrounding the question of whether lowering blood pressure is beneficial or harmful for brain health. So from the model that I showed you earlier, we might expect that blood pressure lowering treatment applied early before there are widespread irreversible vascular changes might reduce the incidence of cognitive and kidney function impairment. On the other hand, if blood pressure lowering interventions are applied later when some vascular changes have already taken place, they might be beneficial, but they could also exacerbate hypoperfusion and impair autoregulation, which we would then predict could increase cognitive and kidney function impairment. So I'm going to talk about blood pressure interventions in two different populations. First, in the end-stage renal disease population, I'm going to talk about the effects of dialysis treatment on blood pressure and what we know about cognition. And then I'm going to move back to the stage 3 and 4 CKD population and talk about hypertension treatment in that population. So dialysis is really an interesting model system in which to study the effects of blood pressure lowering on cognitive function. Speaking as a non-geriatrician, one of the challenges, it seems to me, of establishing a relationship between blood pressure or hypotension and cognitive impairment in the general population is the relative infrequency of hypotensive events and the difficulty of capturing those events when they occur in ambulatory patients. On the other hand, during hemodialysis treatment, blood pressure is lowered during the process of ultrafiltration, and hypotension, either symptomatic or asymptomatic, can occur and be captured. And the degree of hypotension and the repeated nature of hypotensive events makes it easier to identify relationships between hypotension and brain damage over a more compressed time frame. So this study that I wanted to tell you about was very clever. It used near-infrared spectroscopy to non-invasively measure cerebral oxygenation in real time in 70 hemodialysis patients during more than 580 hemodialysis sessions. What they found is that when hypotension was defined as a MAP less than 80 millimeters of mercury, 57% of dialysis sessions involved a hypotensive event, and 6.8% of the sessions led to cerebral ischemia. When hypotension was defined more stringently as a MAP less than 60 millimeters of mercury, 24% of dialysis sessions involved a hypotensive episode, and 10.8% were associated with cerebral ischemia. Importantly, what they also found was that cerebral ischemia, but not blood pressure or hypotensive episodes, correlated with reduced executive function when these patients were followed for 12 months. One of the other important observations from this study is that the lower limit of cerebral autoregulation varied substantially among patients. And these observations may explain why it's difficult to detect an adverse association between low blood pressure and cognitive function in population studies in the general population. If we look at observational studies among hemodialysis patients, we see that there is a marked increase in the incidence of stroke around the time that dialysis initiated, which is shown on the left-hand panel. Again, supporting the idea that these hypotensive events associated with dialysis and dialysis initiation may have adverse consequences for patients. The right-hand panel is illustrating the trajectories of cognitive function among three groups of patients. The top line is the trajectory of executive function among a group of patients with advanced CKD, that is a GFR of less than 20, who do not start dialysis over 2 years of follow-up. The dotted line is showing the trajectory of executive function among hemodialysis patients over 2 years of follow-up. And the middle line is showing the trajectory of cognitive function among patients who progressed from advanced CKD to ESRD and started dialysis. And you can see that there appears to be an accelerated decline in executive function around the time that dialysis is initiated. Again, sort of supporting the idea that events that happen around the time of dialysis initiation, which may involve exposure to hypotension, could have adverse consequences. This is another study published earlier this year that corroborates the findings from the McEwen study I showed you 2 slides ago. Again, it shows that hemodialysis-induced transient declines in cerebral blood flow correlated with longer-term cognitive decline. And in this study, they included brain imaging and showed that it also correlated with progressive cerebral white matter hyperintensities. And finally, I just wanted to share one clinical trial on this in this area. So this is an interesting trial which randomized a small group of dialysis patients to cool dialysate versus standard dialysate. And without going into an in-depth explanation of the physiology, I think it's suffice to say that cool dialysate has been used widely anecdotally to improve hemodynamic stability among patients who are prone to intradialytic hypotension. So the reason this study was interesting is that they showed that randomization to cool dialysate not only improved hemodynamic stability, but reduced progression of white matter damage as these patients were followed over 12 years with follow-up neuroimaging. So going back to the CKD population, if hemodialysis-induced blood pressure lowering is associated with cerebral ischemia and cognitive decline, I think a logical question is, what are the effects of blood pressure lowering in patients with earlier stages of chronic kidney disease? So this is a study that is a secondary analysis of 2 RCTs on target, which involve more than 25,000 patients with vascular disease or diabetes who are randomized to telmisartan, ramipril, or the combination. And Transcend, which is a study of almost 6,000 participants randomized to telmisartan versus placebo. Cognitive function, which was assessed by the MMSE, was a secondary outcome. And the participants were followed for a median of 56 months, and about 25% of the participants had a GFR less than 60. So what they found was that baseline albuminuria, which is shown on the bottom x-axis, was associated with an increased odds of cognitive decline. And then more interestingly, pardon me, if you progressed from normoalbuminuria to either micro or macroalbuminuria, your risk for cognitive decline increased. And similarly, if you progressed from micro to macroalbuminuria, your risk for cognitive decline increased. So one of the first studies to show that your risk for cognitive decline parallels declining kidney function or markers of declining kidney function. What they also found is that the treatment arms lowered systolic blood pressure by somewhere between 1 to 2.5 millimeters of mercury in on target and by about 4 millimeters of mercury in Transcend, but had no effect on cognition in either study. However, they found the treatment effect was modified by albuminuria among those patients who had albuminuria more than 300 milligrams per gram. Treatment with an ARB and or an ACE reduced the odds of cognitive decline by more than 50%. So this finding supports the idea that kidney disease and cognitive impairment have a shared pathogenesis and that treatments to improve one may also improve the other. The next study that I wanted to touch on, I'm sure all of you are familiar with. I'll just run through briefly. SPRINT, which, as you know, is a randomized clinical trial of more than 9,000 non-diabetic adults at high risk for cardiovascular disease, randomized to a systolic blood pressure target of less than 120 versus less than 140. Both kidney function and dementia were secondary outcomes. Median follow-up was shorter at about 3.5 years, whereas the systolic blood pressure difference they achieved was larger than in the previous studies, about 13 millimeters of mercury. And here what they found is that the SPRINT intervention reduced the incidence of MCI by about 20%. It also reduced the composite endpoint of MCI, or probable dementia, though it did not, the effects on dementia alone did not reach statistical significance. However, the SPRINT intervention also led to an increased risk for incident CKD and an increased risk for acute kidney injury. And so this finding doesn't fit with the working hypothesis that the two conditions might respond similarly to blood pressure lowering interventions. So what might explain these somewhat unanticipated results? Well, one reason is that the intervention effects in terms of dementia appear to differ among the patients who have chronic kidney disease compared to those who don't. So this forest plot is showing that the intervention had a favorable effect on reducing the MCI outcome among patients who didn't have chronic kidney disease, but really had no significant effect on those patients who had chronic kidney disease. Of course, this is one of many subgroups that were tested, so we have to interpret this with caution, but this might provide some insight into what's going on. And then another explanation may be that the declines in kidney function that we see in SPRINT related to hypertension lowering may be transient and or they may not lead to permanent damage. So this is a study, again, published recently after follow-up of the primary SPRINT results, showing that although the SPRINT intervention led to increases in creatinine, it actually led to decreases in urinary markers of kidney tubule damage. So reflecting or supporting the hypothesis that these may be benign changes in renal hemodynamics, similar to what we see when an ACE inhibitor or an ARB are initiated, rather than indicators of tissue damage. So that brings me sort of to the end, and hopefully I've showed you that the evidence that the kidney may be a window into brain health, and that changes in markers of kidney disease appear for the most part to correlate with changes in cognitive function, and that persistent declines in kidney function may identify patients who are at risk for cognitive decline. And so I think it supports this working hypothesis that CKD is a useful model for understanding how vascular risk factors and interventions targeting vascular risk factors such as blood pressure affect brain health. So with that, I'll stop, and thank you so much for your attention and the opportunity to speak.
Hi, this is Leah. Thank you so much. Huge thanks to all three of our speakers for their excellent presentations. Now is the time for any questions that you have for all of our speakers. So as a reminder, if you could please type your questions on the Q&A tab on the right side of the screen and type in that box. Then we can read them to our presenters. I might get us started with a question based on the last presentation. It's very interesting. Lifestyle intervention for preventing memory decline with aging and preventing dementia is really a rising area, and there's a new study, the U.S. Pointer study, being funded by the Alzheimer's Association. But there was a study in the Netherlands that looked at nurse-led vascular risk factor reduction intervention that showed no effect at preventing dementia. I'm just curious as to how you think the kidney might be affected, or they seem to be ignoring the kidney in their main outcome. So I was just curious on how your work relates to that, or how there could be some synergy there.
That's a great question. I am not aware of studies of clinical trials which have yet published on this. I could be wrong, but I think this may be the topic of a secondary study from the LIFE study, which was, as you probably know, an exercise study in older adults. There is observational data to support the idea that healthy lifestyle, exercise, etc., is associated with a lower incidence of CKD, but I'm not aware of any clinical trials.
Thank you. We do have a question. Let's see if I can see the whole thing. So, as a patient with CKD, what questions do you suggest when discussing my concerns of having 3 CKD and experience of cognitive symptoms? Are there seminal studies, or is there still a working hypothesis?
I'm not sure I understand the question. What? Could you read it again?
Yeah, so I think it's getting at, so as a person with CKD, and if I'm bringing up concerns of having both stage 3 CKD and experience of cognitive symptoms, do you talk to, or what questions should I ask, or what do you talk to me about the relationship between them, or do you feel that's still a research hypothesis and doesn't get into clinical care?
Well, I think both. So this is still sort of a model, and there's still, I've somewhat oversimplified things in my presentation, so there are some things that haven't quite been worked out here. I guess I would say from the clinical side, I would recommend talking with providers about how cognitive impairment might interfere with your ability to manage both CKD as well as other medical problems, and how how that might be addressed.
Yeah, I would just add to that too, Manju, saying in some of our clinical programs, we've shown that maybe as many as 1 in 5 people who come to see a nephrologist might have some problems with memory. But oftentimes that hasn't been detected before, and the nephrologist may not be aware of it. But when we talk to the nephrologist about this, there are ways that sometimes the management plan can be simplified, or they can help work with patients to prioritize. And so just recognition of that is not always good, and so it might be just recognizing the challenges that patients face may be helpful for individualizing the care plan.
Great, thank you.
And this is Heather. I had a question too, which is sort of for all of you, because in the pilot study, it used sort of this framework of concordant and discordant multiple chronic conditions, and around sort of an index condition of kidney disease. So, I mean, I guess I would like to ask kind of all of you to reflect a little bit on how easy or hard it is to make that distinction of whether a comorbid condition is truly discordant or not. And I actually think that cognitive impairment is kind of a good example, because on the one hand, certainly the cognitive impairment that kind of transiently follows dialysis would be in kidney failure, I would think that is kind of a concordant or directly disease-related sort of comorbidity when people feel like they're not thinking clearly on dialysis days or just after dialysis. But I wondered if you all could sort of reflect on the difficulty of categorizing some of these and maybe using cognitive impairment as an example.
I think it's a good, really good question, and it does point out the complexity in this. In some of our focus group work, we even showed for some other conditions that a condition may have components of it that are concordant and components of it that are discordant. And so it's a complicated issue, and sometimes trying to summarize that in an index like we did might miss out on some of that complexity. The other issue might be kind of from whose perspective and where are you looking at it. And I think the work on blood pressure and cognitive decline and its overlap with kidney disease might point to population level issues where treating these conditions together may have benefits for the population. But at a patient level and in the clinic, issues around under recognition of that problem, the impact of cognition on self-management, and its under recognition, I think point to it being a challenging situation, one that doesn't fit in the same type of category as diabetes, where if you come in and you have CKD and diabetes, the guidelines recommend certain treatment for you because of that pair. Well, there's no discussion of dementia and CKD in the kidney disease guidelines. So I think to me that's where I feel like it fits more into that category. But I think your point is really important, that when we're thinking about mechanisms, when we're thinking about population health, when we're thinking about individual patients, how we categorize these issues could vary.
Yeah, thanks.
Christy and Barrett, I'm wondering if you had any advice or if you could share learnings as you were funded through our pilot, the Aging Initiative pilot program, for other investigators, junior investigators going down that path. Did you have any specific barriers in conducting your work, or what? I'd appreciate your thoughts on what you have to share.
Barriers. I don't think we had too many barriers. Barrett, it seemed to go rather smoothly.
Overall, I think we had early on there was some question about which should be the primary site versus the subcontract, and kind of working through. That's something we might have thought about before we did the submission, because we kind of had to change it afterwards based on where the work was going to be done and what seemed fair, and how to best maximize the funds. And so that may be something we would have thought of earlier, but it didn't really become a barrier. I think this was just overall really a fun process. And I knew Christy before this, but got to know her better and also know the team better. And then Rashida, who was another partner in this, it was a great opportunity for Rashida, I think, speaking for Rashida, to meet Christy, and overall a really good experience.
I mean, it is a short time period as well, to get a project done in a year, and so picking something that can be done in that time frame is, and obviously when people put in their proposals and they're thinking about that needs to be part of it. But I think Barrett had done a lot of preliminary work and his other papers that really laid the groundwork and the framework to do this pilot. So that, I think, was helpful.
Great. I appreciate your sharing your thoughts. Are there any other questions from those participating in the call, or if speakers have questions for each other, we can do that as well? All right. Well, I guess then we will wrap up. I want to thank everyone for attending today's webinar. The recording for the webinar will be posted soon on the Aging Initiative website, where you see the link there. And a reminder, as you sign off, you'll be prompted to complete a very brief survey regarding your thoughts or opinions you had today about today's webinar. We'd really appreciate if you take 60 seconds and complete that for us. Thanks to everyone, and have a great rest of the day.